Hello, my name is Sara Bliss, and this short video is on the practical considerations for parenteral trace elements. The primary objectives for this short video are to review normal trace element functions, lab values, and monitoring, outline causes, signs, and symptoms of trace element deficiency, outline causes, signs, and symptoms of trace element toxicity, define parenteral nutrition trace element dosing considerations, list parenteral trace element product availability, including single and multi element presentations, and apply knowledge to patient cases. The provision of trace elements is an important aspect of parenteral nutrition to ensure the delivery of essential nutrients. Parenteral trace elements that are generally required include chromium, copper, manganese, selenium, and zinc. This video addresses practical considerations related to copper, manganese, selenium, and zinc. Please note that chromium is not included in this discussion as it is not a component of any of the multi-trace element products and has been found to be a contaminant in other products such as dextrose, amino acids, and other trace element components. In fact, long-term PN patients have been reported to develop chromium toxicity. First, we will go through the normal function, pharmacokinetics, lab values, and monitoring for each of the four trace elements included. Copper is involved in iron metabolism, connective tissue maturation, neurotransmission, and energy production. It is absorbed in the duodenum, proximal small intestine, with minimal absorption in the stomach. Routes of elimination include bile, intestines, and renal. Monitoring parameters include serum copper and serum ceruloplasmin, using the equation on the screen to interpret those lab results, as well as urine copper, superoxide dismutase activity. Manganese is a cofactor for several enzymatic processes and is absorbed in the small intestine and is eliminated via the biliary system. Reliable biomarkers for determining manganese status have not yet been identified. Selenium is involved in glutathione, iodine, and thyroid metabolism, cardiac functioning, cell growth, and apoptosis. It serves as an antioxidant and has insulin mimetic properties. It is absorbed in the duodenum, and routes of elimination include renal as well as some fecal losses. Monitoring parameters include serum selenium, glutathione peroxidase in plasma and red blood cells, as well as thyroid function tests. Zinc is involved in cellular metabolism, glucose metabolism and insulin secretion, immune function, wound healing, protein synthesis, and sex organ development. The sites of absorption include duodenum and proximal jejunum, and routes of elimination include the intestine. Monitoring parameters include serum zinc, alkaline phosphatase, and may also include copper status for patients who are on zinc supplementation. Next, we will talk about some of the causes of trace element deficiencies. Copper deficiency can be seen in long-term PN patients without copper, burns, continuous renal replacement therapy, gastric secretions, bariatric surgery, short bowel syndrome, malabsorptive disorders, and high GI losses, prolonged enteral zinc supplementation. Manganese deficiency is very rare but can happen in long-term PN without manganese. In fact, deficiency has only been reported in a single child with short bowel syndrome. Selenium deficiency can be seen in patients with long-term PN without selenium, breastfed infants of mothers with poor nutrition or low selenium levels, continuous renal replacement therapy, intracutaneous fistula, malabsorptive disorders, maple syrup urine disease, phenylketonuria, prematurity, or proximal small bowel resection or malabsorptive disorders. And zinc deficiency can be caused by long-term PN without zinc, alcoholism, breastfed infants of mothers with poor nutrition or low zinc levels, burns, immune disorders, liver disease, pregnancy, prematurity, renal disease, or short bowel syndrome, other malabsorptive disorders, or otherwise high GI losses. In the event of a deficiency, it may be appropriate to consider a dose increase, and you can refer to the dosing section for examples. Signs and symptoms of trace element deficiencies will be discussed on this slide. First, we'll start with copper. Signs and symptoms include bone pain, impaired wound healing, iron deficiency as a secondary cause, myelopathy, neutropenia, leukopenia, anemia, and/or pancytopenia, optic neuropathy, skin and hair depigmentation, or osteoporosis. Signs and symptoms of manganese deficiency include abnormal bone and cartilage formation, ataxia, suboptimal reproductive performance, congenital abnormalities in offspring, growth retardation, or defects in lipid and carbohydrate metabolism. Signs and symptoms of selenium deficiency include alopecia, ataxia, cardiomyopathy, decreased thyroid function, growth retardation, reproductive failure, and myopathy. And signs and symptoms of zinc deficiency include acrodermatitis enteropathica, alopecia, altered taste and smell, decreased immune function, delayed sexual maturation, diarrhea, growth retardation, impaired wound healing, and night blindness. Toxicity can be seen in certain at-risk populations. Starting with copper, patients who are at risk include those with hepatobiliary impairment or Wilson's disease. And signs and symptoms of copper toxicity include abdominal pain, blue-green GI output, bradycardia, growth failure, hemolysis, hypercholesterolemia, hypotonia, liver failure, metallic taste, neurologic impairment, peripheral edema, photophobia, and renal failure. Manganese toxicity may occur in patients who receive long-term parenteral nutrition with or without liver disease. Signs and symptoms of toxicity include hyperirritability, violent tendencies, hallucinations, disturbances of libido, ataxia, Parkinson-like motor dysfunction, such as tremors, difficulty walking, or facial muscle spasms, immune system and reproductive dysfunction, nephritis, pancreatitis, and hepatic failure. Toxicity can be associated with selenium in patients with renal insufficiency, with the exception of those who are receiving continuous renal replacement therapy, which is more likely to be associated with a deficiency. And signs and symptoms include anorexia, dyspepsia, fatigue, gallic aroma of the breath, hair and nail loss, hypersalivation, hyperpigmentation, peripheral neuropathy, rash, and seizures. And finally, signs and symptoms of zinc toxicity include abdominal pain, anemia, and anorexia. Parenteral dosing of copper, manganese, selenium, and zinc can be found in the appropriate dosing for parenteral nutrition asking recommendations at nutritioncare.org using the link on your screen. Prior to considering a dose increase or dose reduction for deficiency or toxicity, respectively, ensure that proper monitoring is performed. Trace element laboratory parameters should be deferred during periods of acute illness or inflammation. Consider obtaining inflammatory markers such as C-reactive protein to help guide utility of the parameters selected. Individual patient trace element status should direct dosing decisions. High concentrations of trace elements may alter parenteral nutrition compatibility and stability, and it is important to ensure that the P and ag mixture is both compatible and chemically stable when compounding and prior to administration. Safety considerations for prescribing, order review, and preparation include using a standardized electronic PN order, also known as a computerized prescriber order entry or CPOE system. And this is what is primarily should be used to prescribe PN for all patients. If a CPOE system is not available, PN should be prescribed using a standardized order template as an editable electronic document in order to avoid handwritten orders. Eliminate transcription of PN orders to avoid transcription errors. And PN ingredients shall be ordered in amounts per day for adult patients or amounts per kilogram per day for pediatric and neonatal patients. This format is preferred over amounts per liter, percent concentration, or volume. An amount per day refers to macronutrients in grams per day, micronutrients in milliequivalents, millimoles, micrograms, or milligrams per day. Clinical decision support should be available within electronic PF orders to alert and prevent prescribers from ordering doses of micronutrients that exceed recommended safe clinical limits or that exceed limits of compatibility. For example, use hard limits when maximum concentrations have been exceeded. Provide clear labeling, and the label should always match the PN order template in the order form or CPOE system, as well as the automated compounding device or ACD. This slide shows the Aspen PN trace element dosing recommendations for adult patients. This slide shows the PN trace element dosing recommendations for infants and children published by Aspen. This slide shows the product availability both as single component and multi component products. It is important to note that there are only two multi trace element products available in the US. One, which is formulated primarily for neonatal and pediatric patients less than 10 kilograms, and another formulation that is intended for pediatric and adolescent patients greater than or equal to 10 kilograms, as well as adults. The doses are here on the screen for you as well. Next, let's discuss a couple of cases. Our first case study is in an adult patient. We have a 56-year-old patient with Crohn's disease who developed a high output small bowel fistula and was placed on parenteral nutrition with standard additives. Over time, he developed a rash around his mouth and a loss of hair. His zinc level was assessed and was found to be deficient. What is it about this patient's scenario that caused this? In this case, high GI losses and the use of standard trace element zinc dosing of 3 milligrams per day was insufficient to meet the patient's needs. How do we go about treating this? We would consider additional IV zinc supplementation up to 10 milligrams per day to be added to the parenteral nutrition admixture. Of course, we would want to recheck the levels at a later time and make sure that the deficiency has been corrected. Next, we have a pediatric case study. A child on home parenteral nutrition for short bowel syndrome is admitted to the pediatric intensive critical care unit with respiratory distress, fever, and elevated C reactive protein and a history of poor growth. The admitting physician wanted to check nutrition labs because of short bowel syndrome and poor growth. Which lab should be delayed until the patient is more stable? A. Selenium, B. Electrolytes, C. Phosphorus, or D. Blood glucose? The answer is A. Selenium. Once the infection, which is likely due to a central venous catheter, is treated, the child's selenium level was checked and found to be deficient. When the home parenteral nutrition formulation was examined, it was found that trace elements were not being added to the bag due to recent product shortages. How is it that we should treat this child? Supplementation with additional selenium in the hospital is an important component, and to ensure that when the patient transitions back to the home setting, that IV trace elements are able to be included in the PN admixture. Initially, the pediatric patient or any pediatric patient with short bowel syndrome may receive a multiple trace element product at home. However, many clinicians will wind up changing patients to individual trace element components and may give patients selenium, zinc, and copper while withholding manganese and chromium due to the fact that the needs of these trace elements can often be met by the contamination within other components of the parenteral nutrition admixture. Of course, it is important to follow up trace element monitoring in the outpatient setting to ensure that patients do not develop a deficiency and that individual needs are customized. Here are the references for this video. This educational offering was provided to you by Aspen, supported by American Regent.